Hello viewers, this is Dr. Rajiv. Welcome to your education channel, YouTube Surgery and Orthopedic Education. Please consider subscribing it as well as share it to your near and dears to help them in their preparation of MBBS course as well as other postgraduate and job entrance examinations. Also, please don't forget to press the bell icon below so that you never miss an update from us. In the last talk, we discussed diagnostic approach for breast conditions that typically included clinical examination, imaging tests, and biopsies known as triple assessment. Today, we shall talk about clinical aspects of a common breast condition, nipple discharge. The nipple is a part of the nipple areola complex NAC, which is a specialized region of the breast with unique anatomical and histological characteristics. The nipple areola complex includes the nipple and the surrounding pigmented area called the areola. This complex can be affected by various conditions including developmental abnormalities, benign processes like inflammation, infection, and tumors, and malignant diseases such as Paget's disease and breast cancer. Clinical signs to watch for include skin changes, pathological nipple discharge, retraction, inversion, and palpable masses. For a detailed evaluation, a multimodal imaging approach is often used, combining techniques like mammography, ultrasound, and MRI to accurately diagnose conditions affecting the nipple areola complex. The finding of discharge from the nipple of a non-lactating woman is a common condition. It may be associated with an underlying carcinoma, albeit rarely. Discharge from the nipple can occur from one or more lactiferous ducts. Its management depends on presence of a lump, presence of blood in the discharge, or discharge from a single duct or multiple ducts. It is important to find out whether the discharge comes from one breast or from both breasts, or it comes from multiple ducts or from just one, and whether the discharge is clear or grossly bloody or blood tinged. Nipple discharge may be either normal or abnormal. In a parous woman, a clear serous discharge may be physiological. It is often clear, yellow, brown, green, or white. It usually comes from both breasts upon squeezing nipples. Milky nipple discharge, either spontaneous or on a squeezing, is also normal or physiological during pregnancy and breastfeeding. Abnormal discharge is usually spontaneous and it occurs without squeezing the breast. It is caused by a disease or pathology in the breast. It usually comes from one breast only, confined to a single duct, and is clear or blood-stained in appearance. Other associated symptoms of an abnormal discharge are pain or a lump in the breast or ulceration or inversion of the nipple surface. Purulent discharge suggests infection. A multi-duct, multicolored nipple discharge is usually physiological. A blood-stained nipple discharge may indicate an intraductal papilloma, intraductal carcinoma, ductictasia, or fibrocystic disease. A black or green nipple discharge is seen in ductictasia. Serous nipple discharge, either clear or of any color, may be physiological or due to a duct papilloma, mammary dysplasia, fibrocystic disease, ductictasia, or carcinoma. Purulent nipple discharge indicates infection. Milky nipple discharge occurs during lactation or rarely due to hypothyroidism and pituitary tumor such as prolactinoma. A multimodal approach is used to evaluate a nipple discharge. Mammography and ultrasound can show an underlying impalpable suspicious mass. Cytological examination through FNAC may identify malignant cells, but a negative finding does not rule out cancer. Hemoglobin test to detect the presence of blood in discharge fluid may be helpful. Hemoglobin detected in nipple discharge may be secondary to an intraductal papilloma, intraductal carcinoma, or ductictasia. The definitive diagnosis needs an excisional biopsy of the involved duct and any associated mass lesion. It is important to note whether the discharge is coming from one breast or from both breasts, whether it comes from multiple duct orifices or from just one duct, and whether the discharge is grossly bloody, such as in trauma, or blood-stained, such as in malignancy. A milky discharge from both breasts in the absence of lactation or a history of recent lactation is called galactorrhea. It may be associated with increased production of prolactin. The radioimmunoassay for serum prolactin is diagnostic, but true galactorrhea is rare. The most common cause of spontaneous discharge from a single duct is a solitary intraductal papilloma. Most common cause of greenish discharge is duct ectasia. Most common cause of blood-stained discharge is duct papilloma. Cancer is a very uncommon cause of discharge in the absence of other signs. Nipple discharge associated with a cancer may be clear, bloody, or serous. Papillomas located away from the nipple areola complex are at a higher risk of malignancy. A papilloma is the most common benign tumor to develop breast cancer, mainly ductal carcinoma in situ. Try to exclude first a carcinoma by occult blood test and fine needle cytology. Simple reassurance may be sufficient if no malignancy is suspected. But if the discharge is causing a troublesome impact on lifestyle, surgery can be done. Two surgical procedures are microdocectomy and Hadfield operation. In microdocectomy, the affected duct is excised through a tennis racket incision or a periareolar incision. Interestingly, a papilloma is nearly always situated within 4 to 5 cm of the nipple orifice. The Hadfield procedure is also known as cone excision or major duct excision. It is done when the location of the offending duct is uncertain or when there is bleeding or discharge from multiple ducts. The entire major duct system is excised and the specimen sent for histopathological examination without compromising the breast contour. The complications of Hadfield operation are altered nipple sensation, nipple flattening or inversion, and difficulty in breastfeeding.